Good afternoon, everyone. At least for me here in Ontario, I am not Martin Kiernan. I am Jim Goche, and I'm hosting the Weber teleclass today, Infection Prevention and Control Practices for Other Congregate Living Settings. It gives me great pleasure to introduce our speaker today, Barb Shea. Barb is a good friend who actually graduated with me 44 years ago as a medical laboratory technologist out of Mohawk College of Applied Arts and Technology in Hamilton, Ontario, Canada. She has spent 25 years in infection prevention and control across the continuum of care, including public health. She has experience in frontline infection prevention and control and also management. Barb's niche expertise is actually in infection prevention and control, construction, and facility design. She left her previous role in construction at the height of the pandemic due to the need for infection prevention and control expertise in long-term care and other congregate living settings. Barb currently manages an infection prevention and control hub team in Ontario, Canada, that services all types of congregate living settings from an IPAC perspective. Barb, I'm looking forward to this presentation.
Thanks so much, Jim, and welcome everybody, and thank you for that kind introduction. And boy, did you make me feel old, Jim. I still think I look a little bit younger than you, Jim, but just saying. But you know, you've worked a lot harder throughout your career, so I'll chalk it up to that. But all joking aside, this is a topic that I feel very passionate about. I felt very passionate about helping out during the pandemic in long-term care settings because of my previous experience at Public Health Ontario and the regional infection control networks, where we serviced a lot of the long-term care homes. And so it does require a lot of adaptation to actually take best practice documents and apply them to long-term care settings, even though they are, organizations that have, policies, procedures, they have, acts and legislation that apply to them. But there wasn't a lot of experience, to be honest, in my background when I took on this role in some of these other congregate living settings. And that's what I wanted to share with everybody today, was some of the experiences that our team have had and the adaptations and the things that we learned when we were out trying to apply the best practices in infection prevention and control. So what I'm going to cover, or try to cover my very best today, is, and the objectives of this presentation are to talk about some of the types of other congregate living settings that we see, knowing that this group is international and that this teleclass is international. I've tried to talk about, not make it very specific to Ontario or to Canada, but talk about it a little bit more broadly, but share our experiences. So what are these other types of congregate living settings that we're dealing with? Talk about or identify some of the existing sources of information, like the legislation and best practices, which are going to vary from country to country, state to state, province to province, obviously, but they all have certain commonalities. And the challenges, of course, associated with the implementation of infection prevention and control, which I'm going to refer to as IPC, so I don't continually trip over my words, and those best practices that are related to IPC, the guidelines and standards. In Canada here, we refer to infection prevention and control as IPAC, but I know that in many parts of the world, it's commonly referred to as IPC. So that's the term that I'll use here. And then I want to discuss, some of the important considerations that we have found in doing the role that we provide related to infection prevention control in these settings, our approaches, and what we had to learn when we were approaching these folks in some of these settings. And of course, there's a lot of similarities, but there's also a lot of differences to settings such as long-term care or retirement homes. And then to talk a little bit about the gaps that we see commonly in these settings and some of the barriers that we see, the reasons why people can't or feel that they can't implement infection prevention and control or IPC in their facility, their home. And of course, some of the ways that we work with them to try to identify some of the things that make it possible, or the enablers, in other words, to implement some of these best practices in infection prevention and control. So this slide just shows, I didn't describe every one of them because some of them are very self-evident, but this gives you sort of a broad kind of categorization of some of the other congregate living settings that I'm speaking about today. One of them is assisted living. So in assisted living, these may be housed, at least in Canada, they may be housed in a variety of different places. So you could have a client that is receiving some assistance. They don't need long-term care. They're not capable of living as independently as they might to just be in their own retirement home, but they need some assisted living. So they might live within a retirement home or a seniors apartment complex, or be part of a long-term care facility, but that has a separate wing for people that are receiving assisted living. So there's a lot of variety here, but they're generally people that have some care provided, not always direct hands-on care with bathing or that sort of thing. It might be assistance to help prepare their meals. It might be assistance to shower. It might be assistance to do light housework. It could be a variety of things, but people are going into their homes. And they may be living, they're living in a bigger complex that has other people there, and they're oftentimes sharing common resources, which is why we consider it congregate living settings. Then there are facilities such as shelters, and there's a huge variety of different types of shelters. So pointing out some of the ones that we have to report specifically about here in Ontario, and that is violence against women shelters, but there's many other types of shelters. Then there's something called intervenor residential services, and that is defined as adults who are blind or deaf. And the next category is adult developmental services that are residential. So these are commonly referred to as supportive housing, group homes. These are kind of common terms that you might hear. And the categories that I've given you on the left are actually just very strict categorizations that we use for reporting purposes here in Ontario. And of course, even though I've listed retirement homes, I'm not really going to be talking too much about retirement homes, because generally they do have some common areas, but they have their own suites typically. But I listed it here because sometimes within retirement homes, we have beds that are available in certain suites. And that may happen in long-term care as well. And there are programs that sometimes house people that are waiting for placement in other facilities. So they will have a bed in this retirement home, and there could be a program where someone comes in, different people manage them, different staff take care of them, but they do require some assistance. And more so, they're usually headed for long-term care in actual fact. And then we have another type of setting that we have dealt with in these other congregate living settings within our area, and that is open custody youth and adults. So these are halfway houses. You might have commonly referred to them as halfway houses. They're facilities that are not locked. They may have young adults or men that go out to work during the day and come back to the facility in the evening. The important thing to know about these types of facilities is they often have daily chores to do within the facility. So they may do some of the cleaning. They may replace hand hygiene product. They're dealing with chemicals and disinfectants. And how do we speak to them? And then they sometimes, clean their own area or space or bed space or bedroom. They may share those with others, but they also may sometimes be cleaning and doing cleaning and disinfection in some of the common or shared spaces. So, this is an interesting type of a setting as well. Now, sometimes I'm referring to them as facilities and sometimes I refer to them as homes, but generally speaking, all of these other congregate living settings, except for these very large open custody youth and adult centers that might house, 100 to 150 people, typically we refer to them as homes. And also it's important to note that many of these types of facilities that are homes, just jumped ahead there. This just gives you a little bit of what I just described here. But many of these facilities that we refer to as homes are often in actual houses. So but others may be in an office building that has had a section of it revamped, or in a little strip mall where a section of it is revamped. And others are very large group homes that have, they may have taken a house. they added a wing, they added another wing, and in some areas we have one mental health facility in our area actually that has 52 residents, and it is exactly that. Has fire escapes. It's a house that's out in the country. It's had many sections added to it, and it has a lot of challenges in terms of the facilities that the home has inside to be able to provide proper infection prevention and control practices. So that's part of our role, is to kind of go there, visit, and help them to adapt the guidelines based on their setting. So sometimes it feels like, when we first started out and we were looking at these other congregate living settings and not having that much experience in these types of settings beyond long-term care retirement homes, we just felt like we were peering into a whole new world. And what is it that we're looking at? So when we are considering infection prevention and control consultation in these settings, first of all, during COVID-19, we had a lot of restrictions imposed on us, and there was directives, and these directives had different applications depending on which type of home it was, based on that that list that I provided earlier, and what ministry they might be reporting to. Now, you may be in a country that has similar, um, public health, legislative requirements where you report certain types of homes or facilities to one ministry. It might be the Ministry of Education. In some countries, actually, it might be the Ministry of Health. Public health, everybody's familiar with that in terms of outbreaks. But, there was a lot of restrictions imposed during COVID-19, which in some ways made it easier to follow. But for us, it made it very challenging because we had 4 different ministries that we were dealing with in order to know the subtle differences between the restrictions that were imposed on each of these types of facilities or homes. And but in some ways it made it easier because there were some rules and regulations, and there was a framework to sort of follow. But one of the other things that we now have to consider is, always is the home currently an outbreak before we go in. So that's one of the pieces of information that we gather before we go. We have to make sure that our staff are safe when they're going in there. I have had staff where they wanted to go with somebody because of the type of home and facility that it was. And usually it was just an unfounded, feeling of uncertainty on their part. And once they got there, they realized that they've got, trained staff that are there dealing with the clientele that are there present in that home, and that it is safe. But it is one of our considerations, the safety of our staff, their staff, and of course their clients. When we're making these recommendations, we don't want to be making recommendations that are going to pose other people, pose a risk to people. So, for example, if we're in a home that has autistic adults or adults with dementia, that we may want to provide alcohol-based hand rub in every common area, but maybe that's not something that they can implement in a way that we would think to recommend, because it would be unsafe and people may not realize and be trying to drink the alcohol-based hand rub, that sort of thing. So we do have to consider the safety of everybody when we're making our recommendations, just like we do in any other infection control program. So that part's not different. The other piece, though, that was a little bit more of a learning curve for all of us on this team was the client's background and their emotional status and their well-being, and making sure that when we were a guest in their home, that we're treating them as as you would if you were a guest in anyone's home, that you're not taking liberty to just ransack through people's things, to look at do you have things stored properly, for example. And I'm exaggerating it to make a point, but because we tend not to do that anywhere. But I think you get the idea that we are, if anything, a lot more cautious, a lot more considerate, a lot more thinking about how it's going to be perceived because we are a guest in their home. And some of the clients may be fearful of the fact that they have who appears to be an expert going into the home, and walking in with some materials to take notes on. They don't know you. And understanding the background of the clients before you enter the house is a really important thing. And of course, anything that we want to recommend, we want to make sure that we're recommending things that everybody can take part in, and that we're making healthcare equally accessible for everything, and that it's flexible and suited to the needs of this particular setting. So this posed quite a bit of a challenge when we were looking at the best practice documents, and a lot of training with our team to because when I first started managing the team, and when we were encouraged to start reaching out to these other types of congregate living settings, a lot of times the reports that I would first receive from the team after they were writing them, when they wrote them, were very healthcare sounding. And that just didn't fit the setting that we were in. And so I realized very quickly that we had to do a lot of training with our staff in terms of using the proper language, because and this happened the first couple of times, and after it did happen the first couple of times, we had training and education and conversations, informal training with our team, conversations about the way that we would speak to the clients in the home, the way that we would speak to the staff in the home, the way that the language that we would use that was not sounding like we were in a facility, that was not sounding like we were in a hospital, was not sounding like using large chemical scientific names that people really can't relate to. Because the feedback that we got early on was that sometimes it felt to them that we weren't understanding what their needs were. So very quickly, we took that feedback and we built it into our program to make it better. So, all of the requirements during COVID-19 to me could be broken down into kind of two main things: communication about all of these things, infection control practices and training, whether we were training people, whether we were telling them about best practices or directives. And of course, when we would visit, our schedules, our protocols, and of course, all the things that we actually do in infection control to make things, work out and make people realize, what they need to do to prevent transmission of infections, because ultimately that is why we're going into these homes. So now that all of these things have been removed in terms of directives and, guidelines, and we're going back to incorporating COVID-19 into what is now, a respiratory guidance document during an outbreak, instead of, a public health document, instead of one that's specifically targeted towards COVID. Well, what do we do now with all of this? So one of the things that we talked about was preparing ourselves for the visit. So preparing ourselves for the visit was to get some background information. So many of the tools that we were using during COVID-19 were checklists. And what we realized early on, regardless of the setting, actually, whether it was other CLS or long-term care, and probably I'm sure it would have been this way for acute care as well, the checklists were long, and they typically extracted a yes or no answer from people. So the question, for example, might be, have you trained people to do a personal risk assessment? And of course, everybody had trained their people to do a personal risk assessment or a point of care risk assessment if you were a healthcare provider providing care. But did they actually know what they needed to think about, or could they demonstrate the things that they needed to think about in order to do that? So when we very early on decided that we were going to treat, our visits, whether they were to long-term care or to other CLS, in a way that would actually help us to extract whether or not the staff in the homes understood, the things that the questions were trying to get at. So instead of asking them a question like, did you provide education about how to do a personal risk assessment? When we stopped and talked to people while we were, visiting a home, we would say, oh, hi, we would introduce ourselves, we would be friendly, make sure they knew that we were not legislative authorities, that we were not writing orders, all that kind of thing. Put them at ease, in other words. And depending on who you were talking to, you would have a slightly different conversation. And then we would, talk to them in this case, so, help me to understand, what you would do if you needed to go in and provide some assistance to Johnny in the room there. What would you think about, how would you do that risk assessment for yourself to make sure you're protecting yourself? And they would, start to describe. If we came out with the, can you tell us how to do a personal risk assessment or a point of care risk assessment? Sometimes the response that we would get would be that they looked confused. They maybe had heard the term a long time ago, but they didn't know the term. So even more in this setting, we want to get the information about the home before we go out to the home, so we know how to speak to the client. We know the education level of the staff that are taking care of the clients in this particular setting. And then we look at, what the residents and client risks are so that we can sort of adapt our visit to that setting. So, one of the things we look at is the risk of infection. Now, in these types of settings, we may think, oh, these people are not going to be as high risk for infection. But in actual fact, many of them are at much higher risk than some of our residents, even in long-term care settings. And there's a whole variety of other congregate living settings, everything from a halfway house with, uh, average adult healthy, average healthy adults to, maybe somebody that's a homeless person in a shelter that's, keeping them out of the cold in the winter, or keeping them out of the heat in the summer. And so there can be a lot of differences between these different types of clientele. So we really do our homework before we go out to the home to assess, what is the client population, and try to get a general idea of what their risks might be. So as I mentioned, some of these people might be experiencing homelessness and be at an increased risk of infection, or have underlying medical conditions, including dementia, liver disease, lung disease, diabetes, heart disease, a lot of these other things, and other underlying mental health conditions. Now, those who are on serious mental health drugs with serious mental health conditions may be on some medications that are actually immunosuppressive drugs. So it's another consideration when dealing with the mental health population. And then, of course, appreciating how to communicate with them, getting that feedback and that instruction from the people that are the experts, because we're not the experts in these things, in terms of the way to talk to the other CLS settings. That's what we rely on our the administrators or the managers or the infection control leads for these different types of facilities. So we're treating them as partners, and we're working on this visit together. So that's really an important piece, as opposed to somebody that takes the approach where they're going in to inspect or review or provide, fill out a checklist and give them the report. And then, of course, the other risks with clients in some of these settings are that they have underlying socioeconomic and other risk factors: smoking, substance abuse, nutrition, lack of nutrition, poor nutrition, lack of education about health, or even access actually to healthcare, even in a country like Canada and the province of Ontario, and in other countries. Some of these factors take a much higher or are much more prevalent than in some of the other developed countries. So depending on where you are, this can vary quite dramatically as well. So by assessing all of the things about the structure that we're entering into, the client population, and how they work and how they operate and on a daily basis, helps us do our risk assessment for how we're going to provide this visit. So we do this, and we spend the time to do this properly before we go, so that we're dealing with, for example, understanding that, are there people in there that have educational issues that may prevent them from us communicating in the same way that we would with others. Because we often talk to residents in long-term care homes and retirement homes. We often talk to residents and clients in these other CLS settings. So it's important to know how to speak to them. And then, of course, I've mentioned these other things that affect their socioeconomic status. So although there's lots of things that influence infection transmission, I didn't want to make this presentation about the usual infection prevention and control stuff that we all have heard a lot about during the pandemic. Transmission depends on a lot of things. The chain of transmission, of course, that many of you have heard about, depends on whether you have a bug to start with. Where is it? Where does it live? Does it live in the body? Is it in the body? Is it in the environment? The place that it resides. How does it get out of the body? Or how does it get spread from one person to another? The mode of transmission. Can you prevent it? Through vaccines, through all of these things, and how does it exit the body, and spread to others. So the whole chain of transmission we could talk about. But what I wanted to focus on was some of the factors that we thought about that do influence infection transmission in these particular settings that we can sort of help with a little bit. So even though we're talking about good hygiene practices, good environmental cleaning, and all those kinds of things in a way that they can digest and interpret and use, we also looked at, the ventilation in the homes. So many of you may have noticed, who have been in other congregate living settings, that many of these have been retrofitted into, as I mentioned earlier, strip malls, office buildings, houses, and they were really never meant to house the number of people that were in there or the type of people. And even though I'm not talking about daycares, daycares are a great example to illustrate this, because daycares, including my own grandson, who was continually sick ever before the pandemic, always getting colds from going to daycare, always getting respiratory or enteric diseases. And I only ever had to pick him up once. And when I went in there, I came home and I said to my daughter, I could hardly breathe in that place. The air was so stuffy and so still, and it was obvious that it wasn't properly ventilated. They couldn't really open the windows. They had a central air conditioning system, but it was definitely not meant to house 30 little germ-laden little children that go around picking their nose and kissing others with an open mouth and slobbering on their toys and that sort of thing. So likewise, even though we're not talking about daycares, the ventilation in some of the facilities are not necessarily adequate. So during the pandemic, you might recall that a lot of people were starting to use high efficiency particulate air filters to help scrub the air. They don't really bring in fresh air, but diluting the air is definitely a way that you can dilute germs, right? Opening windows where you can, where safety allows that to happen. So these are some of the things that you can look at and discuss when you're out at these homes. Their ability to test. They may not have any testing capabilities to find out what people have. And certainly after COVID-19 is over, this may be the case. We're all falling back into, we have the cold. We don't really know whether we have a rhinovirus, a regular coronavirus, COVID-19, possibly a metapneumovirus, or some of these other things. Do we have, are we testing people? Do they have access to a family physician? So some of these things are not always possible for some of these people, especially in the homeless shelters. And of course, we want to make sure that staff have access and have learned from the pandemic that certain things can protect them. And so we do try to focus on the availability and the use of personal protective equipment. It may be gloves, it may be masks, it may be both, it may be a face shield. And so really trying to reinforce that. And one of the things that we learned during the pandemic was, because it was so prescribed in many settings during the pandemic, what everybody had to do, that we thought as infection control practitioners that after it was all over, this would be great. People would understand how to use personal protective equipment, when to use personal protective equipment. But that was actually not what we experienced. We experienced that there was, a need to do re-education, that was confused with use of PPE, was sometimes confused with the things that you needed to add on, which might be called, additional precautions or transmission-based precautions, because somebody had something. You thought it might be COVID until they got tested, if they could be tested. And when all of that went away, now we've got the regular respiratory stuff going on, or the regular, symptoms of diarrhea or vomiting, enteric disease, that kind of thing. And people are not sure what to do anymore. So it was really important to actually emphasize and make sure that people had a clear understanding. And when I say make sure, I mean have discussions with them that talked about that, and friendly discussions where you kind of had friendly scenarios that you sat down around the table with when you visited their home to try and think of ways that they could prevent spread to themselves when some of their clients were sick. And of course, that also included making sure they didn't come to work sick if they, could avoid it. And then the types of accommodations. So there was such a variety of accommodations in this other CLS setting. So you could have a shelter that had people that came in during the day, for example, that were accessing, food services there at a particular shelter. It could be a Salvation Army, for example, shelter. But then part of the facility had people that slept overnight there, that were there for a few days at a time, but then had to leave, so they had a place for 2-3 days, and then they had to leave and somebody else took their spot. And many of the stretchers were very, very close together. They may have barriers that they built to put in between those that were on rolling wheels. They may not have, we might have had to talk about those things, with them when we went to visit. But now that the COVID-19 is over, it's about revisiting all of those recommendations and talking about it in a more general way. Hopefully there's less people with respiratory symptoms going on, now that COVID-19 is sort of settled into routine respiratory, one of the routine, I'll call it as routine as we can make it, respiratory viruses, where now they're incorporated into a respiratory guidance document here in Ontario, for example, and no longer having a separate document about COVID. But it doesn't make it less, make it less able to be spread if you're not using the proper precautions. So, are you separating people the best that you can? But the types of accommodations might have people with shared rooms, might have people with same rooms. And I'm going to talk about a couple of scenarios that illustrate this when I get to one of the other slides. So I'll leave that for a minute. And then, of course, there's cleaning and disinfection. So everybody knows that if you clean and disinfect stuff, you have less things that are capable of being picked up on your hands, and whether it's our hands or the client's hands or the resident's hands in that home. But it's not that they always have access to the same chemical disinfectants that we have in a healthcare facility, like a hospital or even a long-term care home. They might not have auto dispensers, so they're mixing the things themselves. So we visited many facilities, and this is actually one of the biggest gaps that we have found in the facilities, is perhaps a lack of understanding about basic cleaning and disinfection principles. So if you live in a house with your family, just like some of these people live in a house with their family members, that are maybe not their biological family, but it's their family for the time, then there are ways that you can still, implement some of these things to make sure that you're preventing transmission. Instead of throwing up your hands and saying, they're all in the same house, they're all going to get sick. We can't help it. Johnny's sneezing. Johnny uses the kitchen. He shares a bathroom with two other people. But there's definitely ways that we can help them to think about some of the cases that they might get and have that thought ahead of time about how they might deal with that. So that's a big part of what we do when we go into these settings. And of course, the general hygiene of the people that are living in the home, and providing them some education that might be helpful, but in a respectful way that doesn't speak down to them or make them feel like they're not clean. But these things go a long way in terms of preventing spread of organisms or germs, as we like to call it when we're in some of these homes. And depending on on who we're talking to in the home, we change our language. So our approach would be, if we're talking to one of the clients, depending on who the client is and what type of client it is, we might use the word germ. And when we're talking to staff, we might use the word germ. But for other staff that might have a little bit more of a medical background, or a healthcare background, I should say, or a little bit more training, we might be able to use, we might talk about, a bacteria or a virus or a microorganism. So we definitely have to, on the fly, just like, changing on the fly in a hockey game, we have to change our language on the fly when we're in these other congregate living settings, depending on who we're talking to. And although it might seem very, very simple, it's actually, it really takes some practice to be able to do this and do it well. So the descriptions of these other congregate living settings, I wanted to bring up, a couple of, scenarios of ones that we had some experience with. So one of them was a group home. It was an open youth custody detention center. It was a not-for-profit Christian organization. It was a male youth, like I said, open custody detention. The home has 5 bedrooms, 2 shared rooms with no more than 2 people in a room. So 2 of the rooms had, 1 or 2 people in them. And they had 1 bathroom with 3 shower stalls, and they had 3 toilet stalls. So they had 1 bathroom that had 3 shower stalls and 3 toilet stalls. So it was a common bathroom for everybody in the home, basically. The common areas included a main floor living room, a kitchen, and a workout space. And so some of the things that we observed when we're in the home, and just simple things. So we're looking for, very similar things that we would if we went into a long-term care home, and to evaluate what are their practices. It might be very similar to what you would look at when you walk on a clinical unit in acute care, just generally speaking. But the way that you approach it is a little bit different. So we saw that they had alcohol-based hand rub, which was amazing. That was great. These weren't things that people generally had before the pandemic, and something that I hope that they can maintain after the pandemic, at least some access, depending on the client population. But we did observe, and this is common, that we will observe expired alcohol-based hand rubs. So you may recall that earlier I mentioned that we have these long checklists that we might go through when we're assessing a facility, and we have them for other congregate living settings too, but I'm not sharing it because even though we use the checklist, we actually, as I said, ask the question to make sure that we're looking for more than that. So the checklist will say, do they have alcohol-based hand rub? So if you go yes and you don't check if it's expired, then you may never find out. If you check and it's in date, that may be okay for that bottle. But if we don't go and look in their room where they store their supplies, especially in a home where we have, people doing multiple jobs, wearing multiple hats, not having somebody necessarily assigned to this role, you might find in their little storage cupboard or closet in the house that they don't rotate the stock. And so there's a bunch of, the new bottles are at the front. So that's great. That's the one that you saw in the dispenser or sitting on a table. But the old stuff that you should be using first is way at the back. So kind of looking for little things like that are a way to help the home to not be in a situation where eventually they're using expired alcohol-based hand rub, because that quite often is the case. And part of the reason for that is that they stocked up a lot during COVID-19 when they could order a lot of supplies from government agencies, that were free of charge, and they still can do that actually. So there's no reason to try and hoard bunches of it. And you have to rotate the stock just like anything else. And then implementing regular auditing of hand hygiene, but we don't talk about it this way. So we wouldn't say to them, oh, you should audit hand hygiene and make sure that you do inter-rater reliability testing between your auditors. And they are going to look at you like you have two heads. And when you leave, they're probably going to throw your report in the garbage and say, these people don't understand what we're doing, because they've never been taught to audit. So a better way to say it is, hey, it'd be a great idea. Do you folks ever sort of think about doing a little bit of teaching about hand hygiene, or we can help you with that. And then, having somebody that could be, the leader for that, or, champion that, we can use the word champion because everybody gets that concept, and it makes people feel important. And even if they don't want to have somebody that wants to be a champion, that's a client, because you have to be careful about that. Sometimes people are not appropriate to use to have what they may consider power and authority over another client. But, so you have to be careful about that piece, but also just talking to them about, it's a good idea that, while you're moving through the day, to do that one-on-one teaching if you see people not cleaning their hands when they go into the common spaces. So we're actually encouraging the same stuff. And I'm saying it in a healthcare way here because these are the gaps that we observe, but we wouldn't write it in the report this way, because if we write implement regular auditing of hand hygiene without making it sound a little nicer than that, they just don't want to receive the messaging. And the same thing with personal protective equipment practices in the home. So, we might do some teaching and education one-on-one when we're there, but we're going to, in the report, make the language softer, make the language, more home-like, the way that you would do it if you went into your neighbor's house and you were trying to suggest some of these things. You wouldn't tell them, oh, you need to implement some regular auditing of hand hygiene because I see your kids all running around here and they're not really cleaning their hands when they should, and they're touching everything. And we just don't talk to people like that. So it's really, and I guess I can't stress this enough, it's really our approach in the language that we use when we're talking about some of these healthcare things, but are definitely important things to prevent transmission. One of the things that we do definitely talk to them about is the use of aerosols versus trigger, or spray bottles. So if you're a cleaner in a healthcare facility and you're using cleaners all the time and you're using a spray bottle that comes out as a mist, it aerosolizes it, and you're going to be breathing a lot of that stuff in. Now, I know that a lot of us do this in our own homes, but even I forced myself to to switch over to flip top lids, because I thought, well, I either walk the walk or, talk the talk, or I walk the walk. If I think it's not that good, and I get it, there's a difference whether you're a cleaner using one of these aerosol misty kind of things all day long, breathing the stuff in, versus maybe we do some cleaning, major cleaning once a week in our house. But all the same, why inhale these chemicals if you don't have to? So we do talk to them about that and try to say, a lot of the stuff that you buy might come like this, but try to find ones that, have a bottle that you can change from a spray to a stream, so that you can stream it out and put it on your cloth. So you don't have to put it on the spray setting, because they're not going to go and order. Typically, they're not going to order from a healthcare distributor. Doesn't mean they couldn't, but typically they're not if it's a small facility, a small group home. So when you've got this home and you've got, two people in 2 rooms, and then you've got, maybe one person, it says it has 5 bedrooms, 2 shared rooms, and no more than 2 people in a room. What we do is we try to talk to them about some of the scenarios. Well, what would you do if you had a case? In this case, they have 1 bathroom, and it has 3 shower stalls and 3 toilets. So if you have a couple of cases, it's going to be very hard to separate, germs, keep germs from spreading around unless you have a plan. So we kind of come up with different scenarios, and we sit around the table and we kind of do a tabletop exercise with them, which they usually kind of find helpful and sometimes fun, and we get people to participate. And it depends on the home too. We might change it up. It might be just a discussion, and it might be sitting at the table having like this exercise. But we try to discuss different scenarios whereby, okay, only one person is sick. They've got respiratory illness. So we get them to think about, does that mean that nobody else is sick? Is it possible they could be, about to be sick, and maybe right now they're still spreading their germs before they come down with the virus? We explain to them that influenza or the flu virus, for example, you can really spread your germs easily the day before, the 24 hours before you actually become sick yourself. So we talk to them about those things, and we talk to them about the different scenarios, and try to get them to think about, what would they do in this case? Well, what about that case? And, how can you have different schedules possibly for cleaning and use of the bathroom? Now, if you have to use the toilet, you have to use the toilet. So what are you going to do when that happens, if it happens to be the sick person? You can't say, well, I'm sorry, but you can only go to the bathroom at the end of the day. You can maybe do that for the shower part, but that's not going to work for the rest of it. So you're going to try to have conversations with people and try to come up with some scenarios and solutions. And that's going to depend on the number of beds, how many people are sharing each bathroom, whether people are sharing common areas or not. And one of the first times when, that one of my team went out, and I had this discussion with them afterwards about the home that they were in. It was a home with six clients, 2 bathrooms, one on each floor. It was a 2-floor home. The staff didn't have a separate bathroom. So which bathroom was the staff going to use if they had cases? You want to try to keep the staff as healthy as possible. So it's kind of talking to them again about the way that they're going to prevent transmission on a regular basis. So that requires regular cleaning and disinfection. You're not always dealing with a case of somebody being ill, but somebody could potentially be becoming ill the next day and just don't know about it yet, just as is the case in long-term care or hospitals. So that comes back to good hygiene practices, education of the people that are in the home about general personal hygiene, cleaning their hands before they go in common areas, things that we didn't think about beforehand in some of these settings because they were in houses, but things that we should be thinking about, in our home. Cleaning your hands before, preparing food, after you use the toilet, before you go into the TV room and share the remote that, your 4 other people in the home are also sharing, that sort of thing. Having some things that people can wipe things down if they can, helping to encourage them to do it. And one of the challenges is in these different types of settings is that some of the clients are responsible for doing some of the cleaning, especially in the open youth custody or adult custody detention centers. Another one that we no longer cover actually that's under our umbrella, but at the beginning and throughout the pandemic, somebody else is now going to be responsible for dealing with hospices. But I put it in there because we do have hospices, or we did support hospices. And an example of one is, it had 10 beds. They had life expectancy of less than 3 months. Their average stay was 12 to 14 days. There was 10 private rooms, and each room had a private 3-piece bathroom. So this is looking pretty good, right? You have 10 of these 10 of these residents have their own private rooms. They have their own bathrooms. So this doesn't have nearly as many challenges as, as what I just described. So, and there's 2 nurses and there's 2 PSWs. So now you can have, a little bit different conversation with them. Now, the information that you're going to provide and the way that you write your report might be a little bit different because you're dealing with people with healthcare background, healthcare training, and that sort of thing. But all the same, these were some of the gaps that we saw. And again, they're very common ones across these types of settings. And they're also common actually in the long-term care homes. Again, expired product, either alcohol-based hand rubs, sometimes N95 masks, reusable spray bottles being used. So that was another piece. It was a spray bottle, but it was also a bottle that they were topping up or refilling. So does the principle change? No. If it can become contaminated in a long-term care home or in a hospital and we discourage the use of it, of course it can be contaminated in this particular setting, but it's something that they might commonly do. If you think about it, I go out and I buy Windex. Sorry to bring up a product name. I buy window cleaner, and it might be in a spray bottle. And then I buy the bigger jug of it so that I can use the same bottle. So I'm not paying as much money for that bottle over and over again. But in reality, these bottles of cleaners, not that window cleaner is a disinfectant, but anything like that that's put in a bottle can be contaminated. And it's no different whether it's in your own home or a long-term care home or a hospital. So having those conversations and having them understand why it is that we're making these recommendations is really, really important. And then, of course, the housekeeping closet had personal items. This is a risk to the people that are keeping their food in there. Maybe they're putting lipstick on while they're in their, little closet or in their janitor closet. PPE donning and doffing not being done properly with these healthcare providers and reteaching that all over again. And then, of course, the hand hygiene and the PPE auditing. In other words, we could probably use the word auditing. So before we go to the visit, as I've already said, and I won't spend too much more time on this, is we get the description of the facility, the services they provide, their cultural background, their staffing levels and their staff education levels, the population of the client that they're servicing or that are living there, and which ministry do they report to, because sometimes they have different requirements for and legislation that they need to follow. And I know this is the case in other countries as well, because some facilities or homes might have to report to the Ministry of Education in some countries, having done some work in third world countries. And then determining the language style and level to use. I've talked about this already. The presence, are there healthcare workers there? Or who are the volunteers and clients are there? Who's reading the report? Who's going to do the most with this report? And making the report friendly. I call it the poopy sandwich. You put the poop on the poop in the middle, and you start it with a nice message. Thank you for letting us, come to accommodating a visit to your home to provide some infection prevention and control advice or, recommendations. And then listing some of the things that you may have observed as a gap. And if there's a whole list of them, you're not going to list a whole list of them in the email that accompanies the report. You want to pull them into the report, because maybe the infection control person that's sort of leading infection control or sort of takes care of it in the setting, you've debriefed with them before you leave, which is a respectful thing to do as well, but they may not open the report because they've already heard it all. But you want the administrator, you want the person that's going to help to support them in an administrative way to open the report. So you want to try to pull them into the report by wording the report in a way that doesn't mention all the gaps, but indicates that there's some other information inside the report so that they open that as well. And then the other part of the sandwich, the backside of the sandwich, of course, is a thank you and a nice thing, and to ask for their feedback in how you can adapt the infection control principles and welcome that feedback. And I always ask for that when these reports are being sent out, because sometimes we get some very useful feedback that helps us to make our next visit a lot better. And then how can they implement these recommendations? Sometimes we can't be recommending things that they just can't implement because they know it and you know it when you're giving them. So what is the compromise? Sometimes you have to compromise. It's not always perfect for infection control. So what's the next best thing? But not taking it as necessarily can't do it, understanding why do they think they can't do it, because maybe some of those things are able to be overcome. But if they truly, don't have the resources to do it, what's the next best thing? And then, and as I said, tailoring the recommendations to the home or the facility. And of course, the demeanor of all of these things are very important, and I've talked about them. So, I've talked about the 5 moments for hand hygiene here: cleaning and disinfection, the use of PPE. These are all basic and important infection prevention and control practices. Here in Canada, or Ontario, you'd be talking about the 4 moments for hand hygiene. They're really all the same moments. We just combine them in a different way to turn 5 into 4, there's a slight difference, but all the same across the world. We're trying to get people to do hand hygiene. So knowing that this could be an international audience, I included the WHO photo there. So when we're doing personal risk assessment, one of the things that we talk about is, do I have what I need before going into the room? So this is generally how we speak to people when we're talking about personal risk assessment. Do you have everything you need? If you were baking cookies, your mother would tell you to get all the ingredients out, that kind of thing, depending, again, on who your audience is. Not speaking down to them. I'll change the story. I'll change the language depending on who I'm talking to. Is there more than one person in the room? So having the conversation about when do they think they need to provide do hand hygiene, making sure and validating that they understand, cleaning hands between different people, even though it isn't in a home environment, but treating it more like the home that it is, so that when you're in the common areas, you're not cleaning your hands before you touch everybody, because that would be like a hospital. And this is their home. They're not going to do that. But the best you can, if you're a healthcare provider helping them out in their room and you've got 2 clients in that room, you're going to clean your hands between them, because it's going to prevent from carrying, most of the germs that are around where they sleep and lie or sit over to the other guy's side of the room or the other person's side of the room and depositing them there. Any little bit of cutting down on movement of germs or microorganisms from one place to another is helpful. And the same thing with a shared bathroom, right? So it's generally, in terms of hand hygiene and when you need to do hand hygiene, the other CLS settings would be more in keeping with a long-term care setting, where you don't clean your hands before you touch every single person out in the hallway, because unless one of the 4 moments occurs or one of the 5 moments occurs. So is the client healthy? Talking to them about, what would you look for if you're going to go into the room? Having them be able to verbalize to you, or helping them to verbalize that you're looking for signs and symptoms. If you hear them coughing, don't assume it's because they smoke. If they're coughing, they're going to get their stuff on you. So what do you need to do to protect yourself? You should protect yourself regardless of the type of setting that you're in, but helping them to understand that it's about, their protection as much as other people's protections, because people can really are motivated by that, and they can relate a little bit more to it. And what do I need to do to prevent germs? What about if they have, I see blood, or they spit on their table or on their floor, they have poor hygiene, making sure it's a house, but in this case, you don't want their blood or body fluids, or you don't want to be touching their open wound, or they have a scrape, or you need to change their Band-Aid and you might be exposed to their blood or body fluids, but putting it kind of in simple language for them, depending again on the healthcare worker and the staff. And then, are my hands and are clean before I'm touching the clean things, or before I'm touching my face? So if I'm going into the supply room, kind of having that, as basic as it sounds about infection control, it's really basic stuff our parents or our mothers probably taught us. You get all your stuff out before you start baking, because if you muck up my cupboards with flour all over your hands and reaching into cupboards, you're going to have to clean all those out. You're like putting flour in all the stuff. We probably have, if you were anybody that did baking as a kid, then you got that lecture from your mother. The same thing with, you came into the house with, filthy, dirty hands because you were climbing a tree out there, playing hide and go seek with your friends. Well, clean your hands. Thanks very much. But we don't need you, leaving dirt and grime behind, on everything in here. So it's the same way. It's really the same thing. We make it sound very technical and healthcare related, but we don't have to talk about it that way in some of these settings. And it's really, again, adapting the language that we're using. So the use of masks, I think this is one of the things that we were, really experienced during pandemic, and I hope it doesn't go away. I mean, when I went to Japan in 2014, um, I noticed that there was all kinds of people wearing masks. This is long before the pandemic. They were they politely wore masks if they were not feeling well to protect others. They had it going on over there before, long before the pandemic. And so I would hope that, if we're feeling like we have a cold, that we might think, oh, it's just a common cold, now that we are still wearing masks to protect others. And so kind of talking about that, making them available, making sure people know how to put them on properly, helping them to understand that it's important to start with clean hands before you go anywhere near your face. And we commonly find gaps in the wearing of masks. And as a matter of fact, we had one staff in one of the, although it was a long-term care home, it was surprising because of the story that was told. The home was an outbreak. They were on the outbreak unit. They were supposed to be wearing an N95 mask, or sorry, it wasn't COVID-19. It was para-influenza, so they could wear a regular medical or a surgical mask, not the N95 mask. But they chose to wear an N95 mask, but were wearing it down around their neck. So they sort of had an idea that they wanted to use extra caution to protect themselves, but yet were really putting themselves at risk, regardless of the type of mask that they were wearing, because it was actually under their chin and around their neck. So, this is a person who's thinking about protecting themselves, but isn't doing it properly. So to have that conversation is really, really helpful. And those one-on-one learning opportunities, they call them intense learning moments, because the person that you talk to, well, hopefully you're not mean. I don't mean it for that reason. You're not going to talk to them meanly or be giving them a heck or anything like that. You're respectful, all that kind of stuff. It's for their own protection. But you're having a nice conversation. But regardless, they're going to remember that, because it was a one-on-one. It was what they call in teaching an intense learning moment for them, and they will probably never forget that. And then you have an advocate for people that know how to wear masks properly. So taking the time to do this when you see people, as long as you're not taking them away from something that they urgently need to be doing, asking them if they have a moment, if they have a minute to have a conversation with you, is basically the same in any environment that you go into. And then cleaning and disinfecting. Always, these are some of the things that we still emphasize, regardless of the type of setting that we're in, that we want to make sure that we remove the soil first, that we need to clean first. That if you're using a disinfectant that is not a cleaner, then you have to have a two-step process, but you want to make sure that you're using friction. If you're using a combination, like in most, in many places, we have combination cleaners that are cleaners and disinfectants, that you're still using pressure, that you're turning your cloth over if it looks soiled, that you're changing your cloths, that you're cleaning from the cleanest part of the room to the dirtiest part of the room. You're not using the same cloth on the toilet that you used on the sink, unless it's in the, at least not the toilet and then the sink at the very least. And depending on how dirty the sink is, possibly not even the other way around either. You might be changing the cloths. So checking the expiry dates of cleaners. And this is one of the things that people don't seem to have a lot of understanding about. They tend to think that it's a cleaner, it's a disinfectant, the hotter the water, the better. That's not necessarily true. So reading the labels, and if they're using wipes, making sure that they're using them appropriately and the right size and only for the things that they should be. So these are common things that we found. So distancing, we're still actually encouraging distancing when people can. You don't have to sit right beside the person watching TV if you can put your chair a few feet away. These are things that you can, doesn't mean that you're treating other people like social, like you're trying to isolate people away from others. But these are common things that we found worked during COVID-19. So why not try to utilize them as much as possible, even in some of these other congregate living settings? And of course, I talked about air quality before, but really having a serious look at that. Where are your cold air returns in a house, or where are they in a building? Your supply air and your return air. Can you open windows to dilute the air depending on the time of year and the weather conditions? Do you have a good central air condition? If you're using a fan, making sure that it's not blowing across where people are sitting and blowing someone's germs from one person to another, including the use of some of these portable HEPA filter units. So all of those things. And a lot of healthcare organizations have resources that talk about positioning of some of these fans and filters, including Public Health Ontario. If anyone wants to, search that online, there's a lot of resources there. And one of the things that I talk to my team about is minimize what you take into the client room. If you're visiting a space or visiting a home or going in there, you're not going to take a bunch of stuff there and put it all over the floor, because some of the places that we visit are not necessarily the most hygienic. So what are you going to bring out? And you might be going to another place. So you have to think about it as though you were a healthcare provider that's doing home visits from one place to another, because effectively that is sometimes what we do. So, but also with regard to them, when they're caring for people inside a room, don't take stuff into the room that you don't need. Removing things in spaces, decluttering so that things can be properly cleaned. These principles are the same regardless of whether it's at home in our own houses or whether we're in a healthcare facility. If you're going to use signs, we talk to them about making sure that, that it's clear messaging, people understand them. Does everybody speak the language that these are in? Do they have pictures so that if you don't speak the language, you can understand what it says? And are there too many so that people are starting to ignore them? Does anybody actually read them? If you asked anybody what they had on a sign, you might be surprised that they don't even know. And then, things to consider, this is what we talk to people a little bit about when we're in there. How are you going to isolate somebody if you have to? Can you isolate somebody? Maybe you don't have an isolation room. You do not have another single space to put this person, unless you're going to put them in the furnace room, which would not be appropriate. So there are all of these considerations to be had. And again, talking to them about the scenarios that they might encounter to try and understand what they might do with some of the information. What about the shared areas? How are you going to deal with that? Is there a protocol that they could follow? So it's steps that they can, in a language, if they're doing some of the cleaning that they have to help with. Is there a contact list? People sometimes say there's a contact list, but they're the only one that has it. Nobody actually knows where it is except for the person that's the boss of the place. So if they happen to be sick, nobody knows who to contact. They don't have a list of contacts, and 3 people call in sick at a particular home. So having access to that, not, being under one person's control. And, is there possibility for housing offsite? The 52-bed mental health facility that we had in our region, when they were struggling during the pandemic, for example, to house people off-site in some of the COVID hotels, they couldn't take them, because the reason they couldn't take them was because they needed specific healthcare providers that understood how to deal with people with serious mental health issues and took serious medications and could provide those medications. They actually didn't need to be RNs, but they did not have that staffing in the COVID hotel. So they had actually gone out to, one of the department stores, one of the, building stores, and bought tents. And this was in the fall, but we knew that it was only a short period of time before it would get too cool. And they put tents up to start isolating people until we arrived on the scene, and we connected some dots for them with some community organizations that helped to provide them some resources to support the people that were ill at the COVID hotel that had experience with that type of population. So another very a good thing to look at, and I realize it's 2:33 now, so I'm going to try to finish up here so that we have time for a few questions. But this is one of the best things that you can do, is the stuff in the bathroom. Most of these other congregate living settings are sharing bathrooms, and what's simpler than either having a place that you can store it in your own room so that you take it back and forth, so someone's not opening, contaminating it, with their germs, using your stuff, or having, if you happen to be so lucky as to have a closet or a cupboard that's big enough to house, people, you can get little plastic bins at a dollar store, for example, and label them and put each person's products in their little basket so they can open the cupboard and actually pull out their basket. These are some of the ways that you can, prevent people from sharing personal items that can prevent, or that can cause transmission of things from one person to another. And, where can the items be stored? What's the cleaning protocol? What happens when the bathroom is shared with a sick person? All the things that I, sort of previously mentioned. But the bathroom is a big one because they're commonly shared. So considerations for common areas, and we've talked really about all of these things, TV rooms and computer areas, the kitchen, who's going to use the kitchen and when? Just because you're sick, does that mean you don't get to use the kitchen? Maybe you can use the kitchen at the end of the day, just before the cleaning happens, or, in the meantime, somebody brings you meals, or you have to make arrangements for how that's going to happen. But these are things that you have to think about. The same as in any other setting, really. Meeting rooms for social workers. Sometimes we forget about, oh, it's just a meeting room, but social workers come in to meet with some of the clientele, and multiple people are going into this room, and then that social worker is going into multiple places. Routine cleaning frequency, and cleaning during when you have clusters of cases, increasing the cleaning that you're doing, or the type of cleaning. The things that we talk about in healthcare actually still apply here. The things that we touch a lot: the doorknobs, the light switches, the remotes, the computer keyboard, that kind of thing. And, can you restrict use of all of these things or not? I mean, it is their home. So it's never going to be perfect, but you want to just try to minimize the amount of the number of possibilities for transmission of germs that you can. Who's cleaning the area, and what kind of training do they need? Because they do need some training. If it's staff or clients, you need to make the education about cleaning at the level that they can appreciate and understand. And we did that in that 117 bed open detention center. We did education sessions with all of the clientele who were cleaning their own rooms, and the ones that were cleaning their shared areas. And they were just, dumping chemicals and mixing it with water, not measuring, not knowing how to measure, that sort of thing. So there's a lot of things that can be sorted out in some of these other congregate living settings to provide them with the right tools to keep the space safe. And then, of course, the furnishings. It's a home. It's great. We have leather couches in our own houses. If you're going to buy furniture, try to buy furniture when you go to replace furniture that is cleanable and doesn't have crevices. If it does have crevices, ones that are big enough that you can get your fingers in to clean, because the ones that are almost a bit smaller can be worse to try and clean than ones that you can get a finger in to wipe out the space or the crevice. Also, that stitching is underneath or hidden or rolled into, so if you've got cloth stitching on a leather couch, it's pretty hard to clean where that cloth stitching is, and it's going to become contaminated with body fluids or whatever else might happen. So looking at furniture from the perspective of cleanability when you're replacing it is a really great thing, or covering it in the meantime. One of the kitchen tables in a house for autistic adults that I was at, that had an outbreak, everybody in it had been sick, and the staff had all been sick as well during the recent outbreak. And on the day that I went to visit, in their dining room, they had a big wooden table that was all sticky and tacky because of the disinfectants that had been used on it. Simple solution that I had suggested while I was there was to just buy a plastic tablecloth at a dollar store, because the table wasn't cleanable. So some of these things are very, very simple things to implement, but maybe somebody just didn't think about them. And then, of course, the considerations for the kitchen and laundry: who uses it? Are they able to clean after themselves? When they put the dirty clothes in the washing machine and they shut the door, their hands are probably going to be dirty. Are they understanding they should wipe the outside, because when they take the clean clothes out, they could become contaminated? This may sound like germophobic kind of stuff, but in reality, we're cutting down on spreading germs around. It's as simple as that. So these are just good cleaning practices. And the types of furniture I mentioned already, and who's doing it, and the frequency, etc. So I think, in summary, in reality, it's really important to do your homework, all of our homework, before we go into these different settings, to understand who lives there, how they need to be spoken to, who are their staff, and that making recommendations that they can easily implement and relate to, from a household perspective. Don't kill the message with healthcare wording, because it'll be ignored if it is. These are some of the things that we did in the beginning and that we learned from. And to offer assistance, as much as you can with I'm using a big word, implementation plans, but when I'm talking to them, it might be, when you want to get going on some of these, things that we've talked about, let us give you a hand, whenever possible. So helping them with those things, respecting them and knowing that and letting them know that you're a guest, checking back with them. It's not like a one-time thing. We tend to think, well, we got that other CLS setting out of the way, but no, going back and trying to help them out as much as we can, because they don't have as many resources as other institutions or institutions, I should say, have. And then requesting feedback. And I mentioned this before, so that we can adapt and make our next report and our next visit better. These are the things that we learned from going into these settings that we really needed to change about the way that we were doing things. And although it seems like the things that are in common, it's because the germs are the germs, and the way that we can prevent transmission is the same. They just don't have as many resources available to them, or the same um, ability to spend the time. So we have to just try to simplify it for them and offer as much assistance as we can, and make it more and ultimately make it very, very understandable for them. So thank you for listening, and I'll take any questions that any of you may have.
Thanks, Barb. That was a great presentation. We're just going to move it along. If people do have questions, I would suggest they go to the Weber Training website and send it in to you. These are certainly areas that pre-pandemic were being ignored. What's on the screen here is we have 3 free teleclasses coming up from the IPAC Canada conference, and then the June schedule is listed here. I'd like to thank our sponsors, who's Diversey, Virox, and Gamma, that help support these teleclasses. Again, Barb, thank you very much for the presentation, and we hope to see you all again